I think it's going to be using our novel therapies earlier in treatment, potentially in combination with the goal of discontinuing therapy. So things like Ibrutinib are working really well even in the frontline setting, but having to take a drug for potentially 20, 30 years or a combination of drugs is really a lot for both toxicity-wise and cost-wise. So I think considering combination therapies, especially for patients who have the potential to get off of those novel therapies, is going to be of great interest going forward. And then what to do with patients who are already on later lines of therapy, if there is a path to cure in those patients, or if there's at least a way to get them on something that's going to give them a meaningful lifespan still. I'm not sure what all is going to be presented this coming year yet. We've been running in the U.S. intergroup from the ALLIANCE a study of Bendamustine plus Rituximab versus Ibrutinib plus Rituximab that accrued a couple years ago, and we're waiting for that data to be mature. I think that that's going to be really exciting. And at the same time, so that study was in patients who were older than 65. At the same time, ECOG did a study of Ibrutinib plus Rituximab versus FCR in younger patients. That one too already fully accrued, just waiting for it to mature. And as well, I'm really excited to hear in the next few years about the German CLL Study Group's early intervention study for high-risk patients where people were treated with Ibrutinib or observed.